Okay, so welcome everyone to the League of Women Voters of the North Country, our forum. And we are a very unique, multi-issue, nonpartisan political organization. We do not oppose or endorse any political candidate or party, but we are very interested in the issues. So tonight for our monthly forum, we have, we're very lucky to have a special guest from the Clinton County Health Department. When I first called, the public information officer said, geez, I'll pass it on to administration, but we're not even granting media interviews right now. So we feel very, very lucky that Margaret Searing is with us tonight to speak about the county's response to the COVID crisis. And some of you may know her. I knew her as a heavenly, beautiful voice from the loft of the Presbyterian Church Choir. She has just a tremendous voice. So thank you for sharing your speaking voice with us tonight. And Margaret, thank you for being here. And please give us a little bit of background about you first. It always helps us to understand where you're coming from.
Well, first, I would like to a big thank you to the League of Women Voters for inviting me to speak to you this evening. One of the, and you will see in the presentation, that one of the important roles that public health plays during really any time, but especially during crises, is to give out messages to the public. And it's been a pretty heavy lift to be able to get our story out, as well as some of the messages that we've needed to get out. So we really appreciate this opportunity. Thank you. As for myself, I am a 1976 graduate of Rutgers University College of Nursing. I spent most of my first part of my career, the first 15 years or so, in various pediatric in-hospital settings at Newark Children's Hospital in New Jersey. And then I moved to Norfolk, Virginia, and practiced there at Children's Hospital of the King's Daughters. Then went north to the University of Michigan and was head nurse at a pediatric infectious diseases and isolation unit at C.S. Mott Children's Hospital. And then after our two sons grew and I was sort of at loose ends, I got back into nursing at the health department here in Plattsburgh at Clinton County Health Department. And I didn't do much practicing of nursing anymore. I did public health nursing kinds of things. And then after about 10 years of being part-time contracting sort of person, I got more involved in administration, took on a full-time job as the quality coordinator at Clinton County Health Department. I am now in charge of public health national accreditation, and also I oversee the public health emergency preparedness program. So that's sort of why I'm speaking to you this evening. I come with some excuses for why I know some of this information. And I am also the planning section chief for Clinton County's response to COVID-19 pandemic. And I'm going to take this opportunity to update you on the COVID situation. And I'd like to start by talking very briefly about SARS itself. It's known as SARS-CoV-19 or COVID-19 or coronavirus, or probably lots of other names. It emerged in Wuhan, China in late 2019. And the red spikes that you see on that surface make it appear to be a crown, they attach to the cells that line your nose or your throat, or worse, in your lungs if you're exposed to it. and then it injects its viral ribonucleic acid into your cell and promptly takes over about 60% of the cell's reproductive system to make lots of copies of itself. And in the process, COVID does a lot of damage, causing inflammation, pneumonia, and in some cases affecting other organ systems like the GI tract, the nervous system, the heart, the kidneys. On March 16th, 2020, about 9 months ago, the first active case of COVID-19 was diagnosed in Clinton County in a traveler who had recently arrived from Florida. Before that, CCHD had been watching this situation as it developed in Wuhan through January. In February, we quarantined a recent traveler from China who did not develop the disease. We met weekly as the virus emerged on the West Coast of the United States, reviewing our plans for a pandemic. Remember H1N1? We kept those plans. And briefing our community partners. But we'll get to that part in a couple of slides. Right now, I want you to consider the circumstances we'd have been in had nothing been done to combat COVID-19. That's otherwise known as herd immunity without a vaccine, and reliance on public health science, including epidemiology, will show us. Now, this is a graph that I'll explain in a couple of seconds. 2 weeks after Clinton County's first diagnosed case, the new positive cases in the county, which is the green line on that graph, were doubling every 4 days. Had growth been allowed to continue without isolation and quarantine, contact tracing and closure of all but our essential services, public health science told us cases were on a trajectory to rise above 3,000 cases by the end of April. And that's the green line, which goes up almost straight up. As bankers will tell you, this type of math is great when it comes to compound interest, but not so much when it comes to infectious diseases. Such a scenario would have sent about 20% or 600 patients to the hospital over the course of just 1 month, overwhelming our hospital system here, much like it had done downstate when COVID hit New York City just 2 or 3 weeks ahead of where we were in the North Country. Instead, after 3 weeks, our new case rate growth began to slow to doubling every 10 days. And then doubling every 21 days, early indications that our disease control and non-pharmaceutical interventions, which we call NPIs, were working. So what you see now is a comparison of the projected cases and then what actually happened. The blue line on the graph to the right shows cumulative cases as we reached 1/10 of what was projected, which was 3,000, and it took 7 months to get to just 300. The purple line beneath it shows those who've recovered. And on the bottom of the graph, which is where we want to keep it, is the red line showing active cases. How did Clinton County slow COVID down? Part of it was luck, but the rest, it takes a lot of organization and a lot of agencies working in a broad coalition that is based on a long-standing tradition Clinton County adopted during the ice storm of 1998 and then cemented after 9/11. We gathered all our key partners, taught them about COVID, began making decisions about what we might need, social services to help take care of isolated or quarantined people from vulnerable groups within our community. We reminded law enforcement of their role in isolation and quarantine orders. We engaged the Border Patrol to find out about international travelers. We work with CVPH, SUNY, community volunteer groups, nursing homes, Office for the Aging, City of Plattsburgh, and we organized our efforts to fight COVID in a container large enough to hold them, which is called Incident Command. We did all this before that first case in March ever occurred. And these are the keys to how we did it. Commitment to science-based planning and decision-making, working together in a coalition that expands as needed, using pre-existing networks and structures and making new ones when they're needed. We place the response in that container large enough to hold it, which is incident command. We had an adoption of a plan that had a clear mission and metrics, and we stayed within the parameters set by our objectives. And we also had some innovation and flexibility, sometimes to spare. A public health emergency had been declared globally, nationally, and statewide, and at the county level. In March, public health joined forces with the County Office of Emergency Management, the county legislature, and the county sheriff's department to form what is called a unified command within the incident command system. Now, incident command structure, or ICS, is a structure we all train in. The command is shown in the top box at the center of this chart, and the 4 boxes beneath that, operations, planning, logistics, and finance, were filled as well. So I'm not sure you can read the names that are in these boxes. Some of them have changed since we began. And indeed, some of the groups are no longer even active anymore. But this gives you a sense of how we simply were able to organize ourselves. I was paired in planning with, believe it or not, a forest ranger from the New York State Department of Environmental Conservation. See, the DEC specialized in incident command, and they were very active at the beginning of the pandemic, helping out across the state. Our liaison officer used the network needed to communicate with our key partner, the hospital. And they had also formed into their own structure for ICS. ICS was developed for fighting wildfires out in California, and it serves very well for all kinds of emergencies. Most of them don't last as long as this one has, but using wildfire as a metaphor for COVID made it very easy to explain our mission to Dave, my partner, the forest ranger. We have 10 objectives, all towards control of COVID-19 to protect the public's health. When statewide reopening efforts began, Mark Henry left the Unified Command at the beginning of May to head up the reopening committee. And we reorganized into a regular incident command structure with the director of public health and 2 deputies at the head. And we formed another liaison to the reopening efforts to guide a safe reopening of the county guided by public health. It also gives us a direct line to the New York State control room, which can be very helpful. And this was our care plan. The overall plan that New York State Department of Health began circulating in late February or March to fight the virus, I believe originated at the CDC. The top line shows cases over time, and the goal is flattening and stretching out that curve, which is a lot what ours looks like, to keep that line as low and flat as possible. The bottom dark blue box indicates pharmaceutical treatments and vaccines for treatment and prevention. We are at the beginning of that phase. We'll need to vaccinate about 70 to 80% of our population to reach a vaccine-mediated herd immunity. It will take months. Disease control measures in the upper light blue box include early detection, extensive testing, contact tracing, and isolation and quarantine. Non-pharmaceutical measures, that purple box, refer to things like clear, consistent communication about avoiding risk, washing hands, wearing masks, social distancing, decontaminating surfaces, increasing ventilation, protecting vulnerable people. We know we've achieved the goals of this plan because our new cases line, at least until very recently, looks a lot like the one here. When the spike goes too high, The plan calls for the contact tracing part to take a break. See that gap in that third line down for contact tracing? And we decided to modify that because we didn't like it. We thought that the virus was not going to take a break and that we shouldn't either. So we figured out a way to safely expand our contact tracing team to members trained from other parts of the county, sheriff's deputies, probation officers, sanitarians. We got Medical Reserve Corps volunteers trained in investigating cases, and some joined the team working in that area using the Clinton Community College Institute of Advanced Manufacturing building. So this was the room that we were loaned out. And this is what the setup looked like. That's the boardroom that we used. And we were able to safely expand our team to meet the number of cases that were rising. During the first wave, the highest number of active cases peaked at 60, and that was during the first week of April. Some places had a second wave during the summer, but we barely had a blip in our curve. We hit our highest active case numbers again on November 11th. So we now know we're in the second wave. So this is how our staff dressed to go with law enforcement to every apartment in 2 senior housing facilities in Plattsburgh to lock those buildings down and prevent further spread of COVID within the community when several cases were identified within those buildings. CVPH Dietary Department provided meals to these folks. Our Department of Social Services helped residents with needs, and law enforcement also kept close contact with them to make sure they got anything they needed during lockdown. It's really been helpful to have a county sheriff's deputy serve as our operations section chief in our incident command structure. We also developed a contingency plan for drive-through testing facility, and we developed this a while back, and then no one needed it, and the CVPH got the contract to do New York State testing, and for quite a few months they performed those tests on their facilities. But when school got back in session, testing went into even greater demand. So in September, we pulled out our drive-through testing plan to help CVPH get a site that could handle a greater capacity of tests with a faster throughput, but for both symptomatic and asymptomatic people. It diverts traffic out of the parking lot near the emergency department to 213 Connecticut Road near the airport, and has worked really well. So one of the other non-pharmaceutical interventions is communication. And early on, for part of our public engagement and messaging, both to message appropriate instructions to help people keep themselves safe and to address public concerns, this was our phone bank. At the peak of calls to the health department, which numbered hundreds a week, these ladies handled incoming questions and concerns from citizens, businesses, and partners. Referrals between the Small Business Development Center and North Country Chamber of Commerce and the Health Department started the county on the road to safely reopening by our second week of operation. While the staff were all 6 feet apart, these pictures were taken before studies found out how important mask wearing is, by the way, and they wanted me to make sure I pointed that out. Another MPI we use a lot is the media conferences and our social media. And we held almost weekly media conferences with our community partners during the first few months of the pandemic. Thanks to Champlain Valley Educational Services, they loaned us their media person to do Facebook Live events with a professional polish. And then we also, of course, used our website and our social media platforms, in addition to statistical updates, we've written and distributed over 50 COVID-related media releases and include frequent messaging on social media. We keep our website up to date on COVID with links for the public and providers. So planning occurs in a context of situational awareness. Globally, COVID took 7 months to get to 13 million cases. 1 million cases are now added every 2 days and have been for the last several months. We'll have reached 64 million cases by the time I give this talk. The US adds about 100,000 new cases and 1,000 plus deaths from COVID per day, every day. We've begun to see the same death rates that we saw on the attack on 9/11 every day. And yesterday was one of those days. 100,000 people were hospitalized in the United States because of COVID infection as of yesterday. This virus is not slowing down. New York State is exerting fairly tight disease control over hotspots in quite a few zip codes, which they're calling microclusters. Clinton County's percent positive rate for testing as of today is 0.8%. The goal is to keep it below 1. But our daily rates are beginning to trend higher now, and we're tracking them to try to keep out of the microcluster zone. So this is what we looked like last week. When this started, as I showed you earlier, we were on a trajectory to get to 3,000 cases in 1 month. We've slowed it down to a little over 600 cumulative cases in 9 months. But it's evident that the current trend is once again moving upwards at an alarming rate. During November, we hit a new all-time high of 118 active cases on November 15th. Our previous record was half of that back in April. And this is what we look like today. And this is not cumulative cases. These are yellow zone metrics. The top one are daily active new cases. So today we had 17 new cases added to our cumulative rate. That's pretty high. The gray line underneath that is the rolling 7-day rolling average of new cases, and that's 8.7. Beneath that, the yellow line is our daily percent of positive tests, and that was 5.8. The goal is to keep that number below 3.5. So we are beginning to get out of our range for that number. And then the 7-day average positive test rate, which is the green line, is 4, which we're hoping will come down again. If you notice, those two lines drop off precipitously. That's because our testing data is 2 days behind our other data. And anyway, this is a graph that we are hoping will get back down into lower territory, because if we reach a rolling new average 7-day average case rate, new case rate of 12 or above consistently, and 3.5 or above in infection rate, we will become a microcluster zone for our community, which will mean the state will be telling us that things need to close down, that schools will need to do more testing. It will put a lot more burden on the county to try to remain open. According to an October 2020 article in the Journal of American Medical Association, the cost of COVID is 90% of our GDP. Just think about that. That's huge. Return on investment for contact tracing efforts alone are figured at 30 times the expense. And yet, absent a local government COVID relief bailout, public health, your county public health department is facing budget cuts that were shown in the paper today to be quite high, actually, and we're not the county that's in the worst shape. Protecting our economy with a safe and science-based reopening has involved a lot of our sanitarians and environmental division helping interpret New York State guidelines to schools, businesses, and local governments, and enforcing public health orders with the help of law enforcement. Some of this may well be put in jeopardy by a lack of a federal response to the need for local government bailouts. So this is just to recap. This is how we have been as successful as we have been. But as you also see, we're beginning to lose our effectiveness in controlling the virus to the extent that we hope to. And we believe that part of that may be due to complacency on the part of people who are sort of been enjoying the success we've had here and no longer taking things as seriously as they need to be taken in order to protect ourselves. What we learned back in June is that we're only on the tip of the iceberg, that the COVID case iceberg of detected cases is hiding many, many more cases. For every case we observe, there are 7 cases underneath it. And for every death from COVID, there are 125 infections, 81 of whom had symptoms and 44 of whom were asymptomatic. That's why mask wearing has become so important to protection. When we talk about diminishing risk, we're not talking about a perfect 100% proven effective strategy or even a group of strategies, but by layering them, recognizing personal and shared responsibilities, we can definitely greatly decrease the chances of getting COVID and really limit its spread. Back when COVID-19 emerged, we thought it was spread by large droplets. Now we know better. A recent study done in Arizona after bars were closed and mask wearing was enforced showed a 75% decrease in new cases. Mask wearing is for everybody, now, all the time you're with others who don't live in the same household with you. Another thing about masks that was recently discovered was that the gaiters and the kerchiefs that people had been wearing are actually worse than not wearing a mask at all, because what those 2 devices did was they just aerosolized the droplets into tinier particles so that they would stay suspended in the air longer. And that is why CVPH is banning the use of gaiters and kerchiefs in the hospital. If you are there, you need to be wearing one of their approved masks. We remain situationally surrounded by a raging wildfire, embers that fall into a large crowd of people gathered at an in-person meeting or wedding, indoors in a bar or restaurant, turn into hot spots, which must be quickly put out with great effort. 20% of COVID cases account for 80% of new COVID cases in super spreader events. We are not safe. Remember the treatment and preventive measures on that plan I showed you? We don't really have any of them yet, though vaccines are on the way and we'll have them soon. We may have one by the end of 2020. It's 95% effective, but will not be ready to distribute to most of the population until well into 2021. What we do have is an engaged community who largely cooperates. Please don't get complacent, especially with the holidays on us. know how to make decisions based on your calculated risk of potential exposure. The health department is working with New York State on various plans for vaccine distribution. There's several contingencies that are being developed, and this may be our new normal even after these vaccines are being distributed, unless a vast majority of the population gives their consent to be vaccinated. And like I said, we need to get to 70 to 80% of our population. We will be wearing a mask and washing our hands and watching our distance, probably for maybe a couple of years to come. I am happy to take any questions you may have at this time. I might not be able to answer them all, but I do thank you for your attention and also for your efforts in wearing masks, in not traveling, not gathering in person with those who are not in your household. That protects us all. Thank you.